Good morning, everybody. I hope all of you must be comfortable right now and having a cup of tea and a coffee along with this program of demonstration of various lesions, especially the valvular ones. To understand and to clear your doubts, what exactly we look forward when we have the valvular lesions. So to begin with, I'm going to show you a couple of clips from a live demonstrations of a recorded patients in my laptop. And then I'll go ahead and tell you what exactly do you look forward in your clinical practice. So first of all, Dr. Subhash Chandra, what do you see in mitral stenosis? Dr. Subhash. Dr. Subhash.
I look for severity of mitral stenosis.
No, what are the features you see in mitral stenosis?
Yeah. And cardiac rhythm along with mitral stenosis, and whether patient can be submitted for balloon valvuloplasty.
No, that's too far away. I'm not talking of those things right now. I'm talking of what are the features you like to see in a mitral stenosis? Suppose a patient of mitral stenosis comes. What features do you see in a mitral stenosis?
Mid-diastolic murmur, opening snap, and rhythm, atrial fibrillation.
Please silent your mics. Please silent your mic. Mobiles are buzzing right now. Your still mic is on. Yeah, go ahead, Dr. Subhash. Dr. Subhash, I can't hear you. Anyway, Dr. Subhash is lost. Let me just show you a couple of examples from my laptop.
I'm back, sir.
Yeah, okay. Tell me what are the features you like to see in mitral stenosis?
How severe it is?
No, I'm not asking that even. If you happen to see a patient of a mitral stenosis clinically, echocardiographically, what all you like to see in that mitral stenosis? My question is very simple. All right, let's start with this particular picture. I hope all of you can see this picture.
Yes.
Okay, what do you see in this picture?
Doming, paradoxical movement.
This is a classical plaques view, which talks of a large LA. And if you look at this mitral valve, AML and PML, PML is almost fixed. It's not opening at all. It's not moving at all. Look at the AML. AML is thickening is when it's more than 5 millimeter. Let's stop and measure what the thickening is. How do you measure thickening? Like we'll go to the diastole, then go to calipers. And then we go for just measurement. Just take a generic one. I'm talking of dimensions. Let's measure any dimensions. I'm not talking of this. Don't take it as an IVS. So we measure at the tip of the mitral valve leaflets. This is almost 4 millimeters. The criteria of thickening is more than 5 millimeter. It appears thickened, but it is not truly thickened. That's what exactly it means by. So when we get rid of all these kind of things and come back to normal imaging qualities, like if you look at this picture, qualitatively we will say this patient has got a thickened aortic valve leaflets, PML is fixed, AML is doming in diastole. What do you mean by doming in diastole? It shows a domed-like feature. Look, it's curvilinear features. This is doming. And this happens because when the mitral valve gets inflamed, the cords get shortened down. This is the primary cord attached to here. There is a secondary cords attached to here. These primary cords, they get shortened so that the opening is not complete. So you get a feature of a doming. So that's what exactly two dimensions echo tells you about. A doming of the mitral valve leaflet. It tells you about thickening. And whenever you have a mitral stenosis, you have a large LA. Look at this LA, which is pretty large. Incidentally, in this patient, concentrate on aortic valve also. I'm going to stop aortic valve. Look at the aortic valve is also thickened. And it's also doming towards aorta. So when you happen to see these kind of feature, aortic valve is 99% associated with mitral stenosis. So I don't say that alone is not there. It is there alone also, but it's associated with mitral stenosis majority of time when we have a rheumatic fever. So this doming of aortic valve is also present. So this patient has got not only a mitral stenosis, this patient has got a aortic stenosis also. Now look at carefully. That was static, and this is a 2 dimensions live clamp. Is that right? Anybody sitting over here can open up a mic. Does this patient have got a significant aortic or mitral regurgitation?
Yes, sir.
Dr. Sapnil, does
Yes,
it
sir.
have
Because
a significant aortic or mitral regurgitation? If it's there,
yeah,
why?
yes. Because sir, our
Yes.
left atrial volume is large.
What is large?
Left atrial volume.
Left atrial volume large could be because of mitral stenosis. If somebody has got a severe aortic or mitral regurgitation, what will be large? LV would be large, not the LA.
Aortic stenosis.
Mitral stenosis has given rise to large LA. If his AR or MR is present, then even LV would be large. That's what I mean to say. Okay, because the regurgitant lesion will affect what? Regurgitant lesion of AR will affect LV, and significant MR will finally reflect to LV. That's one of the criteria for severe aortic or mitral regurgitation. Anyway.
I beg your pardon. I think severe MR can also dilate the LA.
LA would be large as it is. I'm not saying no for LA. If as associated MR is there, LV would be large. Okay, let's move further. Let's look at this short axis view. What do you see? This patient does have a severe aortic stenosis or mild aortic stenosis or normal aortic stenosis. Look at the wall thickness. Wall thickness is only 11 millimeter. Then posterior wall thickness is only 8 millimeters. This is 11, this is 8. If somebody has got a severe aortic stenosis, what will happen to LV wall thickness?
Increase, sir.
Hypertrophy will be there.
Increased.
Hypertrophy will be there.
Hypertrophy would be there. But what happens if the patient has got associated mitral stenosis? It may or it may not, because the volume is constricted or volume is small when you have a severe mitral stenosis. So we cannot put emphasis on alone and LV wall thickness when we are looking for a aortic stenosis in patients who have MS with AS. Little bit on the higher side for you. Anyway, let's forget about it. Let's go much further. This is what is known as cusp separation between two leaflets. I'll go back to my previous clip. I'll freeze it. Go frame by frame. Now this is the maximum distance I could see between two leaflet cusps. So I'll go and measure it again. I'll pick up anything dimensions and I'll measure from a tip to tip. It's almost 1.2 centimeter, little on the higher side. Anyway, what did we measure at the time was 0.74. So anything less than 6 millimeter is considered as severe mitral stenosis. One of the parameters for talking of mitral stenosis. Now look at this color flow now. What this color flow tells you? There's a turbulence at the level of mitral valve leaflets when the blood is moving from LA to LV. It shows multiple mosaic pattern or multiple pizzas. If I have to tell you what this lesion is MS and MR. What is the dominant lesion is? The dominant lesion is when this pizza is towards LA, it's a dominant lesion for MS. If it's towards LV, this dominant lesion would be MR. So this patient has got a significant turbulence, as if the blood is trying to get out of this mitral valve. That's what it's trying to look forward. So we have a dilated LA, we have a thickened mitral leaflet, restriction cusp motion, doming of AML, fixed PMO, and then significant turbulence across this mitral valve opening. And the cusp separation is 0.74 centimeters, which is moderate. I'll not say severe, which is moderate. But that's not a classification. Classification is always dependent on mitral valve area as well as the gradient across this mitral valve. So till now, we possibly say that patient has got a significant mitral stenosis. Let's move further. LV function in short axis looks to be reasonably normal. I'll go for the mitral valve features now. Now look carefully what exactly is happening. With every diastole, lot of blood which is going from LA to LV and shows significant turbulence. Right? And what we do, we just put a continuous wave Doppler across this. We can start with a pulse wave Doppler, but we switch over to continuous wave Doppler when we look at this particular phenomena. So what are we going to do? We're going to put a Doppler, then switch over to continuous wave because the high flow gradients are there. Then what we see, we just trace this Doppler envelope. So I'm going to trace it for you. Let's see what I'm going to do. So I'm going to trace from a baseline, go gradually up, go to peak, come to bottom, and then go to the next complex that's tell you about a heart rate. So what I got in this? I got peak velocity of 2.54, mean velocity of 1.76, peak gradient of 25, mean gradient of 13 millimeters of mercury at a heart rate of 76. Anybody can tell me this is a mitral normal NSR or it is an atrial fibrillation? Dr. Prasanjit, NSR or atrial fibrillation?
Normal sinus rhythm.
Why normal sinus rhythm? If this is not this, this is this. Why? Why normal sinus rhythm?
Because there is P wave before each and every ventricular complex.
No. There is
ECG. Tell me about a Doppler feature.
envelope is same.
There is presence of A wave over here. This is atrial
There is
kick.
A wave.
This is atrial kick. This is E wave. This is A wave. If E and A are present, this is a normal sinus rhythm. If A is not there, then it's an atrial fibrillation. Okay.
The ECG bill also is normal there.
ECG is also normal there, but I'm asking for a Doppler feature at the present moment. I do agree ECG is normal. So what I did, I traced the Doppler envelope and then I traced this Doppler line across from a peak to bottom of this particular phenomenon. So what is the pressure half time? Area by pressure half time is 1.1 to 1.4 centimeters square. So it's classified into what? It classifies into severe or very severe mitral stenosis. Deepak.
Moderate was.
Severe mitral stenosis.
Severe mitral stenosis. What is the classification for severe mitral stenosis?
1 to 1.5 is severe mitral stenosis.
That's 2014 guidelines. 1 to 1.5 is a severe mitral stenosis. So till now, what we have got is we have got a gradients of mean gradients of 13 millimeters of mercury. So 13 millimeters of mercury will classify into what?
Severe, sir.
Severe or very severe?
Very severe is more than 15.
More than 15. Okay. So we are classifying into severe mitral stenosis with the area by pressure half time. So till now, what we have looked? We have looked at the dilated LA, we have looked at thickened mitral leaflets. Then in mitral valve, AML is domed, PML is fixed. Then we have a cusp separation of 0.74, then a gradient of mean of 13, mitral area 1.1 to 1.4 centimeters square, and then a significant turbulence across the mitral valve leaflets by CFM. And all this classifies still into severe mitral stenosis. Now, what is the most important thing which is left in this particular patient? Not Nitin.
Planimetry.
Pardon?
Sir, mitral valve area by planimetry.
Perfect. Sangeeta, you are great. The most important thing which is left in this patient is mitral area by planimetry. Because that is whatever the issues are, whatever is happening in the world, you have to demonstrate the mitral area by a planimetry. And that's what exactly I have done in this next clip is I've gone and measured the mitral area in planimetry. So how do you measure mitral area in planimetry, Sangeeta?
So we have to go to the short axis view at the peristernal short axis view at the level of mitral valve.
Correct.
And then at the mid diastole, we need to do the planimetry. And if the commissures are open, we have to include the commissures as well. At the
We
tip
have
of
to
the
include the commissure always because
Yes.
commissure involved inclusion is most important thing in this subset of populations. Good morning.
Yes, sir.
Correct. So Sangeeta said perfectly, we have to go and do a mitral valve. My computer got fixed up. Hang, give me a second. I hope it will come back. So we look at this mitral valve area by planimetry. So I'm going to, it's got stuck. Anyway, so we have to look for mitral area in planimetry. And that's what I'm going to show you. Give me a second. Okay. I'll come back again. It said stop sharing. I'll go back to it. It is gone conked off. So give me a second. So Sangeeta, what would be how do you go to mitral valve area by planimetry? Or what is the procedure you will follow?
Sir, we have to go to the peristernal short axis view at the level of mitral valve.
How?
So you mean how we fix the probe?
No, how do we go to mitral valve leaflet tips? Because that is the most important thing. Once you are measuring mitral valve area, then how do you go to really the tips of the mitral valve leaflets?
So tips we can really visualize in the peristernal long axis.
No.
The mitral valve tip.
You are close by because that is the only take-home message which is important over here. Now, see a mitral valve. How do you say this is on the tips or this is the funnel level or at the annular level?
So by setting the gain properly, we can.
No. Anybody else would like to try? Deepak, you would like to try?
Sir, we look for the papillary muscle.
Perfect. Go ahead.
And at that, and we tilt the probe just upward, and we see the mitral wall at that level.
We go from what exactly happened is look at this four-chamber view. If I'm doing a cut section at the level of papillary muscles, so what exactly happens if we go to short axis view? The first thing what we see aorta or mitral valve leaflets, correct? From aorta to mitral valve leaflets, we'll go to papillary muscle level first and then gradually comes towards the mitral valve. The first thing what we'll see is mitral valve opening. And that's how in short axis view, we get to mitral valve area. We have to be very sure that we are measuring at the tip of the mitral valve. That is the only art in mitral stenosis what you need to require to have. Right? Is that clear, Sangeeta?
Yes, sir.
go to papillary muscle level, come back towards mitral valve, and at the tip of the mitral valve leaflet, you will find this mitral valve filling. Fortunately, this technique has become evolved over a period of time. How did it evolve over a period of time? I'm going to show you. I hope this clip plays and does not get hanged again. Give me a second. This is really has evolved over a period of time. Now we have a 2 dimensions or 3 dimensions echoes at our disposal. When we have a 3 dimensions echo at disposal, look at this clip is trying to play. I hope it does not get hanged again. We just cut at the tip of the mitral valve leaflets and it gives them a short axis view at the tip of the mitral valve leaflets. Can you see a bottom clip on the bottom side or left hand side of a screen?
Yes, sir. Yes, sir.
So what exactly this is trying to do is a cutting at the tip of the mitral valve leaflet, and we get the same thing what we are getting in 2 dimensions. And then we do a planimetry. I'll just show you how to do a planimetry, because that is the most important part of any echo program, any mitral stenosis evaluation, to calculate mitral valve area by planimetry. And if you're a novice, and if you have, yeah, got stopped, I'll do it again. So that is possibly a culprit clip. So this is what is mitral valve stenosis is. When we look at this mitral valve stenosis, we have to look at the tip of the mitral valve leaflets to calculate mitral valve area. And what is the classification, Sangeeta, for mitral valve area is?
Sir, as per the ACC, after 2014, if it is less than 1.5, it is more severe. If it is less than 1 centimeter square, it is very severe.
Correct. So if you look at those classification of ASC, ACC guidelines, so if very severe is the one where we look for interventions, correct? And severe is if the patient is symptomatic, only then we talk of interventions. Otherwise, we do not talk of intervention in severe mitral stenosis. So I'm going to calculate the mitral area. Unfortunately, that clip is getting hanged. I'm going to show you that clip over here. Now, in measurement, I'll stop this clip first, correct? And then move frame by frame to get the maximum dimensions of mitral valve. Correct? Is that okay? Maximum opening is fine. We can look at the lateral commission, we can look at the medial commissions, and then we trace the entire inside, which I'm going to do for you. So I'm going to go to area, mitral valve area by planimetry. I can start from anywhere, wherever I feel like. Whatever is good for me, I'll do that. There's no compulsion that I should start from this point to this point. But I have to be really a good interface. And in beginning, like majority of us will struggle to get the maximum good mitral valve area. So it's 1.8. It has gone to progressive mitral stenosis. So what you can do at your levels? The best answer for doing at your levels is, I'll go back to that again. Try to zoom up this picture for you. Controls, yeah, here is a zoom. I'm zooming up this picture for you. So at your beginning level, what you can do is just zoom up this picture, stop it, move frame by frame to get the maximum best mitral valve area. Now, look at this picture. This picture is much better than the previous picture, correct? Is that okay?
Yes, sir.
Correct.
So I'm trying to zoom up to the best possible max size. So I'm at right mid diastole. Now I'm going to go to measure, go to generic and areas, and then mitral valve area. Now I'm going to trace this inside. I can start anywhere, wherever I feel like. This is my domain, like where I want to start. I want to start from Agra, or I want to start from Belgaum. So it's 1.8 to 2 centimeters. So it's not only severe, it's a progressive mitral stenosis. Anything less than 1, severe, very severe. 1 to 1.5 is severe. And then more than 1.5 is very severe mitral stenosis. Oh, sorry, progressive mitral stenosis. One more thing which is left before we go ahead further. this is where we have TR jet gradients. What is the normal approximately TR jet gradients? Anything more than 30 millimeters of peak TR jet gradients. So this patient has got 3.46, 46 millimeters of a TR jet gradients. Is that clear?
It will come on. We have to do that. Correct.
So we'll just put a cursor at the tip of the mitral tricuspid valve leaflet, do a continuous wave Doppler. We get a Doppler regurgitant jet and just put a tip at the tip of the tricuspid valve leaflet. I can do it for you. There's nothing rocket science in that. What I'm going to do is just put a caliper at the tip of the tricuspid regurgitant jet. It should be at the tip. Look at me. It should not be at the beard level. It should be at the level of chins. That's how we look for TR jet. Thank you, Manoj. So it should be at the level of chin, not at the level of beard. So anything more than 30 is considered as abnormal. So let's go back and recollect what all features of mitral stenosis are. Sanika, you are listening to us, right?
Yes, sir.
Open your Sangeeta, not Sangeeta, Sanika Kadam. Oh, she's not there. That's not good. Anyway, let's move on to Dr. Avinash Solanki. Avinash, are you there?
Sir, I am there.
Sanika
Hello.
is there. Perfect, Sanika.
Yes,
Tell
sir.
me what all did we listen right now in mitral stenosis, Sanika?
So we are checking the structure of the mitral valve,
Right?
area of the mitral valve, gradients about the mitral valve.
We go by one what we looked at. We looked at mitral stenosis in plaques window. We looked at dilated LA. We looked at thickened mitral valve leaflets. AML was doming. It was thick. PML was fixed. Then we went to mitral valve cusp separations. Then we saw turbulence across the mitral valve level where the pizza was forming in LA. Right? That's how we'll go.
Okay.
What next is, we went to four-chamber view. We saw turbulence at the level of mitral valve levels. Again, we did a continuous wave Doppler across the turbulence. And then we took a Doppler pattern or spectrum pattern that we analyzed by doing a tracing. It was a normal sinus rhythm because it was A wave was also present. Then we took a peak and mean gradients and area by pressure half time.
Yes.
Correct. And then we went to planimetry of the mitral valve area in short axis view at the level of tip of the mitral valve leaflets. And then we went on to do a TR jet gradients.
Yes.
Okay, now the question, Sanika, you said everything yes. Now tell me, suppose your mitral valve area by pressure half time is 1.9 and your pressure by planimetry is 1.6 or 1.7. Which one you will prefer?
As per sir, you're asking about the severity.
No, I'm taking like my area by pressure half time is 1.7, 1.9, and by planimetry is 1.6. Which one you will pick up?
Planimetry.
Oh, wait a minute, Dr. Subhash Chandra. You are an extremely intelligent person. Sanika she's growing right now. Give her a time, breathing time. Sanika, tell me, which one you will pick up?
My planimetry.
By planimetry. Okay, good. That's a good answer, planimetry. But why will pick planimetry? My pressure half time was very good.
Because we are taking at the tip of the mitral valve level.
Oh, that's fine. That doesn't make any difference. You have to have a reason for that. Why I'll pick up planimetry, why not I'll pick up pressure half time?
Actually, we are giving, while we are giving the reporting, that time we are giving the pressure half time also.
If you are giving the pressure half time is, that's good, you're giving it is okay. But if I have to give a choice between two, okay, I'll give in a different fashion. Suppose my mitral valve area is 1.4 by planimetry and 1.8 by pressure half time. What you will label that patient as?
Very big difference.
Pardon?
Not sure, sir. I'm not sure of this answer.
I'm not able to hear you clearly. Okay, Dr. Subhash, now your turn.
Yes. Planimetry, if it is 1.4, I will label it as severe mitral stenosis.
No, my question is a little different, Dr. Subhash. I said planimetry is 1.4, pressure half time is 1.9.
Direct visualization is better, sir.
I think
Prasanjit, hold on for a second. Hold on for a second. Hold on. Please hold on. Dr. Subhash Chandra is
planimetry is better than pressure half time. So I will go according to planimetry. If it is 1.4 square centimeter,
Why
I will leave it.
planimetry is better than pressure half time?
It's a direct visualization of the valve.
Anything else?
Can't say really.
All right. You got stuck now. Prasanjit, now your turn. Why?
Sir, better to take the worst value, sir. And direct visualization is
No.
direct visualization.
Pallavi Horo.
So it is not volume dependent. Heart rate. So by planimetry, the
Pallavi, you're close by. You're not exactly.
so the measurements in planimetry are not affected by the preload afterload.
Perfect. What do you explain? What do you mean by preload and afterload?
So preload is the current volume volume status of the
Volume
heart,
status of a patient.
and the afterload is the pressure against which the heart has to work to pump out the blood.
Correct.
The blood.
So this is dependent. And can you give some example to everybody why I'm stretching on pressure, not stretching on pressure of time? I'm stretching on by area, by planimetry.
So because the mitral valve annulus and the configuration changes by each cardiac cycle, and each cardiac cycle is dependent on these parameters of.
Very good. Pallavi is perfect. You know, God bless you, beta. From where do you belong to, Pallavi?
So I belong to Lucknow. Matlab I am working in Medanta, Lucknow.
We're working in?
Medanta, Lucknow, sir, as a cardiac anesthetist.
Oh, wow. Great, Pallavi. You made my day today.
Thank you, sir.
God bless you. Now, Dr. Subhash, you can understand Dr. Prasanjit. Suppose I've got a matter like severe anemia. What will happen to my pressure half time and gradients? Suppose I'm volume depleted. What will happen to my pressure half time and gradients? Suppose I've got a severe hypertension. What will happen to my pressure half time and gradients? All these things will not be dictated when we are taking a directly pressure mitral valve area by planimetry. So the take-home message for mitral stenosis is spend time on planimetry. Do it as many times. If you really ask me how many times do I do when I've got a mitral stenosis, I may be doing about 8 to 10, 12 times. The only thing in mitral stenosis which I'll do is always spend time on calculating mitral valve area by planimetry. And if I've got 10 or 12 pictures of mitral stenosis, pressure measured by planimetry, the average will come automatically. 1.8, 1.7, 1.85, 1.76, 1.79. So you know close by that my mitral valve area is 1.8 centimeters square. Is that clear? Dr. Prasanjit, is that clear?
Yes, sir. That is clear, sir.
So well, I'm sure like all of you sitting over here, the 45, including me, understand how do we look for mitral stenosis. Any question can open your mic and go ahead further. I've tried to explain the most simple way of looking at mitral stenosis. Rupali, go ahead.
Sir.
Rupali first.
Sir, sir, in book now there is mitral valve area ka formula. I mean 0.785 is there. Pi r square pi and that day we used the 3.14.
No. Rupali, that is something different. That's the formula you're trying to look is by continuity equation. Forget about that continuity equation.
Acha, so that 3.14, that pi r square LVUT area into
That is for
LVUT
aortic, will utilize in aortic stenosis, not in mitral stenosis.
But mitral valve area may also that formula is there, na, sir?
Leave it up.
Okay.
Okay, Dr. Swapnil?
How can we differentiate if there is MR and MS? You are saying that turbulence you have to see whether which is more dominant, whether MR or MS.
Okay. I'll go and share that clip again. You know, all these things we learn with experience over a period of time. Correct. Now look at this mosaic, multiple rings of a color in LA, towards LA.
Yes, sir.
If they're made in LA, possibly the dominant lesion is MS.
Okay.
If this is during diastole which are made. If they are made during systole, in my LV side, in mitral valve, is possibly an MR would be dominant.
Okay.
Second important thing, if it's MR which is dominant, what will happen to LV size?
It will be increased.
Right. The most important criteria for MR is dilated LV.
Okay, sir.
Right?
Yes, yes.
Okay. Dr. Rajesh Gupta.
Why we have to see TRZ gradient? You told the last point in MS.
Very good question. Why do you want to see a TRZ gradient? What is the utility of it? Where exactly the ultimately dilated LA raised pressure will reflect to?
Yeah.
Lungs,
It will,
lungs.
Lungs. From lungs where?
Back to the RV.
Where to
PAP,
RA?
sir. To PAP.
To RA.
Yeah.
If my LA is MS is significant, what will happen to my pulmonary artery pressure?
It will increase, sir.
You got the answer.
Okay, sir. Thank you.
Narendra Kumar, Dr. Narendra. Speak a loud. Narendra, I can't hear you.
Am I audible? Hello.
No, not yet, man.
Hello. Hello.
You better buy a mic, Narendra. I'm not able to listen to you at all. You can post your question.
Hello. Am I audible?
Yeah, better now.
Sir, you have said that in case of the measurement of mitral valve area by the pressure after and by telemetry, so in case of the increased after load, so pressure half time gives more area, so more mitral valve area.
We are not going to discuss that right now over here. It will be variable. Let's talk of a level 1. Because if I'll go to that level, things will change dramatically because I have to talk of multiple things.
Okay.
It will change. At your level, just think of mitral area by planimetry. Okay. So I'll move on to my next talk. Subhash, you want to ask something before I move ahead?
Yeah, please go ahead, please.
Okay. So I'll go to my next presentation. Give me a second. I'll go to my next presentation.
Sir, how we can get the importance of plaques view that you showed caliper, like the distance between anterior leaflet and posterior leaflet.
Right.
So there we should consider that.
At the tip of the leaflets.
No. If you check that, you are checking at 3 levels by planimetry, by pressure half time, and then in plaques view also. So all 3 you are testing, but you are considering more about planimetry only. So where we should consider that measurement.
That is the best. Any mitral stenosis in any condition, think of a planimetry.
But in PLAX view, yeah. But when
PLAX
you
will
see
give you an idea. It will
idea. Okay.
Severity.
Okay.
Look,
Okay.
suppose a patient comes, I have to decide what I have to do with this patient: medical management versus surgical intervention.
Okay.
So the planimetric area of less than 1.5 centimeter to 1 centimeter, if the patient is dyspneic, symptomatic, grade 2, grade 3 dyspnea, obviously that is the time when I'll try to intervene in that patient. If it's less than 1 centimeter square, dyspnea or no dyspnea, patient needs the intervention.
Okay.
So the take-home message is spend time on planimetry. The rest of the things will guide you. Look, this is possibly the answer is. But rest of the things will not guide you that this is the only answer. That's not that. So only answer will be given by planimetry.
Okay. So tip to tip distance will be just supportive. Support for us. Yeah. Okay, sir. Thank you.
All right. So what's next is aortic stenosis. So now look at this aortic stenosis in this patient. Yes or no? Wall thickness 12 and posterior wall is also almost 12. Anything more than 12 is considered as hypertrophic. But look at the LV size. LV size is normal, 46, 36, but it is indexed. So is this size normal or abnormal?
Valve architecture, it is aortic stenosis present, sir.
No, I'm not asking wall. I've not gone to wall architecture. I'm still at basal level. Is this LV dilated? Is normal or abnormal? First,
it's dilated, sir.
Is dilated. This is Sangeeta Chaudhary said dilated. I do not agree with Sangeeta Chaudhary. Anybody would like to disagree with Sangeeta?
Yes, sir.
Mahesh will disagree. Why do you want to disagree with Sangeeta, Mahesh?
Because LV size more than 55 to 56. Then we call it as a dilated, but 46, I believe it is normal.
It's 58, man.
58, yeah.
It's dilated.
Then, so it is 46. We cannot say it is dilated.
46 is dilated. The patient's body surface area is only 1.4. Look, the most important part is nobody one of you have observed. Look where we have done a cut section. We have done a cut section in the mid level of LV. Where we should do a cut section? At the proximal LV. We should measure from this point to this point. If I have to measure this patient's of LV dimensions, I'm not going to measure there. I'm going to measure from this point to this point. Is that right?
Yes, sir.
It's only 47.
4.7.
So we have to be very careful when we talk of something. Even this will be little less because I have measured at this 47. This will be little less of this. Yeah, 47, 49. Divide by 1.5, it will come out to be almost, it is dilated, no doubt, but as per body surface area. But you have to really look at the measurement where you have done the measurements. But this is thickened, no doubt about it. It's 12-13 millimeters, 14 millimeters. Posterior wall thicknesses. Almost 11-12 millimeters or more. So this is possibly suggestive that LV is dilated. And when LV is dilated, then you have to look at whether it's truly aortic stenosis or not. We have to be really, really careful. Just hold on for a second. I'm going to hold for a second. Just give me a second. There's a call which is coming from the hospital. I have to pick it up. Okay, all right. Let's go to what is the next feature for aortic stenosis would be? We go to first. Let me go to this plaques window. Look at this plaques window. What do you see in plaques window? Thickening calcification at the aortic valve levels. Correct? This is mitral valve. Yeah. Now anybody can say why my LV is dilated?
Sir, there is MS with AR here.
Oh.
MR with AR, sir. Sorry. Yeah, MR. Yes, I saw the MR jet, sir. Now. In the LA.
Look, AR is also present, MR is also present, man.
Yes, sir.
So both of them are contributing to dilated LV.
Yes, sir.
Correct?
Could be associated with AR.
Pardon, sir?
It could be associated with aortic rigor.
Perfect. I do agree. Look at the severity of it. We'll come back to it later on. So what is our point right now is we see turbulence at the aortic valve level. And when we see turbulence at the aortic valve level is we start looking for aortic stenosis. And the most important part of aortic stenosis is we have to have a thickened aortic valve leaflet with restriction of cusp motions along with thickened LV. Because it is aortic stenosis is a pressure generating technique. Like what happens to muscle bodybuilders? Their muscles build up. So for aortic stenosis, the LV has to build up to push up pressures. So it's a very rare. I can show you an example where patient has a severe aortic stenosis but does not have LV wall thickness. At the same time, so at your level, a patient has to have a normal LV and thickened leaflets with LV hypertrophy, anything more than 12 millimeters of LV wall thickness. Then next, we go to 5-chamber view. So what do you see in 5-chamber view? You see a forward turbulence across this aortic valve. Lot of turbulence across this aortic valve in the forward. Forward means when its LV is contracting, the blood is flowing from LV to aorta during systole. And at this time, when I put my Doppler flow pattern, what is I do get? I get this Doppler flow pattern like this. So this is stenotic flow. This is regurgitant flow. If I have to look at regurgitant, we'll come back to later on. This is regurgitant flow. This is stenotic flow. And when I look at this stenotic flow, I'm not concerned on regurgitant flow at present right now over here. I'm concerned at this stenotic flow. So how do I do it? I'm going to trace the stenotic flow for you. Let's trace it again at the tip of a chin, not at the tip of beard. So I'm going to utilize the modal velocity. What we say is the modal velocity is when we do at a tip of the chins. So I'm going to take this modal velocities. Connect to next one, I get a heart rate. So the velocity is 3.32 peak, mean is 2.55, aortic valve gradient is 44, and mean gradient is 28 millimeters of mercury. And aortic valve pressure half time is VTI is 71.4 centimeter. Heart rate is 54. So what is the cutoff criteria for severe aortic stenosis? Dr. Deepak?
More than 60, sir. More than 60 peak pressure gradient.
64. No. Don't tell me now. I'm going to tell you what is my pressure gradient of 60. What we take the pressure gradient
mean more than 40 is
mean more than 40
is also
more than 4 meters per second. So we do not classify into peak, neither we classify to mean. Peak velocity more than 4 meters per second and a mean gradient of more than 40 millimeters per mercury. Correct? So here we don't classify into either peak velocity nor mean gradients. This is one window. I have utilized only a 5-chamber view. Correct? So if I have to look at which all windows we should utilize this particular phenomena. Dr. Oja, good morning. What are the windows you would like to utilize, Dr. Oja?
For the ASR,
right.
We can use the 5-chamber view.
Correct. Flax view for what? For gradients? Don't tell me flax view, man.
Oh, then we can use the 3-chamber view.
Right.
Supraesternal view. Supraesternal.
Right.
Right paraesternal.
Right paraesternal.
Right paraesternal.
Correct.
Then right anterior oblique view.
Correct.
And subcostal view.
Perfect. So Dr. Oja gave an exact answer. We should utilize all 6 windows for calculating the maximum gradient. It may not be maximum in this particular window. It could be maximum in other windows. Other windows is we start from the apical window. Plaques, we do not find any windows. Apical 5-chamber view, apical 3-chamber view. Then we go to subcostal window, 3rd. Then we go to right paraesternal window, 4th. Then we go to suprasternal window, 5. And right anterior oblique view, when we talk to you about this, we put a pillow behind only right shoulder to raise the right shoulder to get right anterior oblique view to get a maximum gradient. So that's one point which is clear. Now the second point is when we put a continuous wave Doppler, we get is the peak and mean gradients. Same thing if I do a pulse wave at the LVOT level. So instead of doing this, I'm going to put a pulse wave at LVOT level. So now I've shifted, look at this box. This box is separated one. So this is at the level of LVOT where I'm going to get my LVOT VTI. So look at this LVOT VTI is only 24.22. And what was the LVOT aortic valve VTI? It was 249.29. No, aortic valve VTI was 64. LVOT VTI is 24.22. Aortic valve VTI is 64.89. Is that okay?
Yes, sir.
So we take a dimensionless index across aortic valve. Now we are coming to conclusion. What is the severity of this particular patient for aortic stenosis? So what do? We divide LVOT VTI of 24.22 by 64.89. Anybody has got a calculator? Just calculate if I am doing the same thing. is 0.37. Anything less than 0.25 will be considered as severe aortic stenosis. Clear? I hope all of you are awake.
No, sir, just a reminder, please.
24.22 divided by 64.89 is known as dimensionless index. We took a LVOT VTI, we took aortic valve VTI, divided these two from each other, from LVOT to aortic valve. And if it's less than 0.25, we call them as severe aortic stenosis. Correct?
Correct.
Now, the next last important point, somebody was talking about LVOT area. Correct? Who was that person who was talking of LVOT area by pi r square? It's Rupali. Rupali, this is now your turn.
Yes, sir.
So what we'll do in this patient now is we'll look at LVOT diameter.
Yes, sir.
And how do we look at LVOT diameter, Rupali?
Sir, in plaques window, in mid systole, we have to measure that hinge points.
Correct. So what I'm going to do is I'm going to zoom up this picture for you, Rupali. So I'm zooming it for this picture. As we said in mitral stenosis, the most difficult point is to calculate mitral area by planimetry. In my career, I started doing echo in 1986, 2022, 16 plus 22 years of my career. I feel the most important and difficult point for aortic stenosis for me is to calculate LVOT diameter. I've taken out the best possible picture. You know, look, I can see my right coronary cusp leaflet and non-coronary cusp leaflet. I've zoomed up this picture. I'm going to stop it for you. And you have to do it many times. I'll tell you why you have to do it many times. Perfect. Can you see this picture clearly?
Yes, sir.
This leaflet is open. This leaflet is open very categorically.
Yes, sir.
And now I have to measure my hinge point from this point to this point.
Yes, sir.
So I've got to measure. I utilize anything from this distance. So I'm going to go to hinge point at this point to this point of hinge point. 1.9. Normally is 1.8 to 2.4. So this is one diameter which will change your complete scenario for calculation of aortic valve area. You have to do it as many times as possible to come to a conclusion. This is the best picture I can get for you, like when my both leaflets are opened up. If I could see only one leaflet which is open and other is not opening up, then take my word, you have to go back, do it again. So you have to spend time. I'm going to come back again on the same picture because this is where you have to really spend time for calculating your mitral aortic valve area. Why it's important, I'm going to tell you in a couple of seconds. Look, the picture will change dramatically. And look at this cursor downside. We have to be mid-systole because at mid-systole, this will be fully opened up. So with one beat is going to make a difference. And if you ask me, this is the only difficult part in aortic stenosis is where to measure my exact LVOT diameter. So I'm going to measure it again. All right, I did from this. Get rid of a CFM. Freeze the film. Stop it. Go frame by frame. and get the maximum dimensions. So I'll go back. Now it's closing. Now this is opening. And I'm going to zoom it up now for you. So this is one hinge point, this is second hinge point, and I'm going to measure this at hinge points. From this point to this point. Now look at again, it's coming to almost 2.1. So that's how, Rupali, you have to do it again number of times. I may be wrong at this moment because hinge point is somewhere over here. Two. So this is how you look at LVOT diameter, 2 centimeters square. Correct? Now I'll tell you what's important. If I'm calculating the flow across LVOT is pi r square into LVOT VTI. This is flow which goes across aortic valve area into aortic valve VTI. Aortic valve VTI is 64.89 and pi r square is, we have got 2, that is radius is 2 divided by half, that become 1 into 3.14 into LVOT VTI is 24.22. Aortic valve area that we have to calculate. Are we clear with continuity equation now, Rupali?
Yes, sir. Yes, sir. My confusion is that same formula we can use in mitral valve area also.
No, we do not use. We can use it when we are in doubt. We can use it.
Okay.
Not in a standard positions, because what will happen if what you are looking forward is the blood flowing across the mitral valve is the blood flowing across aortic valve, which will take aortic valve as the other parameters, right?
Mm-hmm.
Suppose aortic valve has got aortic regurgitation, then the formula become waste.
Okay.
So in aortic valve area, we'll use this formula of continuity equation. The blood flowing across LVOT. Over here would be the blood flowing across aortic valve. So I got LVOT diameter. So diameter divided by 2 will give me radius. So pi r square, radius square into pi, 3.14 will give me area at this point, multiplied by VTI. So that will give you the volume of blood which is flowing across LVOT. Other side, I've got only VTI. So if I divide this volume of blood by VTI across aortic valve, I get aortic valve area. Is that clear to everybody?
Yes, sir. Yes.
Yes, sir.
Because the take-home message for aortic stenosis is we have to calculate aortic valve area. And if this dimension is variable, suppose somebody measures 1.8, another measure 2, or third measure 2.1, the total equation will change dramatically. So in today's circumstances, when we are talking of somebody as a severe aortic stenosis, if I'm in doubt, I'll get a cardiac CT done to look at my LVOT diameter. Or I can go to a planimetry transesophageal area. They'll give me a true planimetry area by transesophageal echocardiography to talk of severe aortic stenosis. That area, Rupali, would be the right area when we talk of as compared to mitral stenosis.
Okay, sir.
Okay.
Yeah.
Any questions now for this aortic stenosis?
Sir, I have a question.
Go ahead.
Sir, in aortic valve area, so which method is better, planimetry or by this continuity equations?
Transthoracic, planimetry.
Okay, sir.
Sorry, transthoracic, continuity equation, transesophageal, planimetry.
Okay, sir.
Dr. Ojha?
Sir, how we measure the stroke volume?
Stroke volume, very good. You got the stroke volume. The blood flowing across LVOT is the stroke volume. So you take what is LVOT VTI into pi r square of LVOT. That is stroke volume.
Okay. Okay.
Dr. Rashiri Karat has asked this question. In presence of significant AR, how do you take exact LVOT VTI to minimize? Rashiri, are you talking about LVOT diameter or LVOT VTI?
Sir, LVOT VTI, because sometimes that AR is fanning, so it's difficult to get the exact LVOT VTI.
LVOT VTI will not be difficult, Rashid. Why do you think it will be difficult?
Because that time the heart rate must be on the higher side, so that extra piece, or I don't know why, sometimes it's not clear dates which we get on the doctors.
Okay, what we are talking is increased heart rate with the AR with AS, correct?
Yes, yes.
In that case, reduce the heart rate, optimize the heart rate, and do it again. When we get this kind of a scenario in our lab, what we'll do? We'll ask the patient to come optimized with the drug therapy, and then we come back again.
Okay.
But in case of AS with AR, contraindication still be valid. Because if AR is present, whatever the blood which is flowing through across LVOT has to flow through aortic valve. Even if the added blood is there, but it will flow through aortic valve. So my question will remain valid. Okay. Your gradient could be high, but contraindication will give me the same valid answer. In case of AS with AR, always contraindication again. But it will be difficult for you to measure your what? LVOT VTI, because at that time, you're to a large extent, you're right, because at that time, large amount of blood flow which is flowing through LVOT will produce turbulence. Yes. So you have to pull your cursor a little back towards LV to get rid of that turbulence.
Okay, sir.
Right?
Yes.
And optimize your heart rate, you will get a better answer. Dr. Venkatesh.
Good morning, sir. In atrial fibrillation, is it significant to measure LVOT, sir? AF, sir.
AF?
As AF is in AF, sir, atrial fibrillation.
Right.
Significant of measuring LVOT, sir. Is it significant to measure, or we should measure LVOT?
No, we'll measure LVOT in every condition, you know. Whether it's AF or normal service rhythm, because by measuring LVOT, then only able to utilize my LVOT content equation.
Okay, sir. Thank you.
But the only problem will come because in one beat you are measuring LVOT, the other beat you are measuring continuity equation. So it made the amount of blood which is being pushed by LV may not be the same in two beats. Okay. Variability could be there.
Okay.
The same formula exists if you have a aortic atrial fibrillation. Utilize 5 to 7 beats volumes.
Okay, sir. Okay, sir.
Dr. Saurabh.
Thanks.
Sir, my question is, in the book it is mentioned that you have to take LVOT VTI by pulse wave Doppler and aortic valve VTI by continuous wave. Is it? I mean, is it a rule of?
Because now let's go back to your question by yourself. LVOT VTI and aortic valve VTI. What is the difference between LVOT VTI and aortic valve VTI?
Sir, LVOT VTI we take in the left before the aortic valve.
Just before the aortic valve, 2 to 3 millimeters or 5 millimeters before the aortic. So it's just site specific.
Okay.
Correct? Now take this cursor to aortic valve now.
Okay.
Once you take the cursor to aortic valve by pulse wave, what will happen? Because of high flow, turbulence will start happening. Okay. So what you will do? You will increase the scale. It will not get contained. Yes. Then you move the baseline. It will not get contained. Then you switch over to continuous wave.
Shift to pulse continuous wave.
Pulse to continuous wave. In normal circumstances, tomorrow in your lab, you go back and do an echocardiography. What you should do, you keep a pulse wave sample volume at LVOT and pulse wave sample volume at aortic valve. It will be same. Because there is no aortic stenosis. So both VTI would be almost the same.
Okay.
right?
So in the case of aortic stenosis, due to the high flow across the aortic wall, there will be aliasing, so we'll have to do a continuous wave at aortic.
What is VTI? Velocity time integral is the amount of blood pushed with each beat, centimeter pushed in each beat. So whenever the stenotic lesion is, the amount of blood pushed with each beat would be more. The distance to which blood travels with each beat would be more as compared to non-stenotic lesion.
Okay. Thank you.
Anybody else before we move on to AR now?
Sir, one question, sir.
Go ahead, Godade.
Sir, in first slide of this AS, you told to measure LV cavity proximally. Means usually we are measuring in mid cavity, but here you told to go slightly proximal. So what was the reason, sir?
I did not say measure proximally. I said where do you measure your LVOT diameters?
Yeah, LV2 diameters at that means proximal to aortic wall only.
Then?
Okay.
Whenever we are measuring our LVOT, LV diameters, we are measuring at just in the basal anterior septum and basal posterior wall. Okay. You go to like measurements. That's what we taught you. Because if the LV will start dilating, LV will start dilating initially right at the mid segment itself.
Okay.
So measurement is always taken at basal levels.
Excuse me, sir.
Go ahead, Dr. Chandra. Go ahead, Dr. Subhash.
I'm Dr. Yeah, if you is mode is of some help in aortic stenosis.
What?
The closer line, the box, the separation of cusp.
Oh, it was there in your age, man, not in this present age.
Yeah. Okay.
It has changed. No, we are talking of quantitative, not the qualitative.
Yeah. Okay.
When we go now to see the girl and a boy, they see each other, they look at each other's height first, and then they measure it.
Yeah. That's right.
At your time, a photograph was enough.
Yeah. Not even photograph.
Not
It
even
was the parent.
You happen to see your wife after the marriage, you know?
Yeah. Parents she used to see before. 1980, it was just the M mode.
Yeah, it was M mode only. True, it was only in 1986 was the first time we had a color Doppler workshop in Ashoka Hotel. It was done by Dr. Naveen Chinanda. I still remember that workshop today, even today also. In fact, I was talking to Dr. Nanda a few days back. I was telling him, sir, I still remember your workshop on a color Doppler by Aloka machine in 1986 in Ashoka Hotel. Anyway, somebody else was asking some question also. Is that okay? Shall I stop it over here, aortic stenosis? Any question for aortic stenosis? Severe aortic stenosis is less than 1 centimeter square. I'm not going to go to the classification of aortic stenosis because we have 4 varieties of aortic stenosis where we look at a gradient flow across aortic valve, and then we call them as high flow, high gradient, low flow, low gradient with normal ejection fraction, and poor LV systolic functions. We're not going to talk about that because that becomes to level 2 and going to confuse you a lot. All right, let's move on to the next session of regurgitations. You guys can pick up a tea and coffee if you're feeling a little too much of all these things today. I'm just trying to show a practical aspect. I'm not trying to show you like, I'm trying to show you what all you can do in your lab looking at all these kind of things. All right, let's move on to MR. So what are the features you'll see in MR? Dr. Raj Borkar.
So we can have exertional dyspnea. Hello. In echo, we'll have the gradient flow across the LA and LV, and the flow will be towards LA. Hello.
Okay, go ahead. Go ahead.
Yes, sir. And sometimes we can, as previously said, we can have dilatation of LA.
First of all, the most important part is, let's go to the morphology of mitral valve. What is the morphology of these mitral valve leaflets, Raj?
Some mitral valves can be flail, sir. They can be
correct. The most important thing is, let's look at the morphology, whether they are thickened, calcified, they are normally moving, they are restricted moving, they have a flail leaflets, or there are some perforation in the leaflets, some vegetation in the leaflets.
Yes, sir.
Correct? Because everything will be dependent on that. Suppose I've got severity. Suppose I've got perforation. So what I'll do with the severity? It's already severe. If I look at a mitral valve leaflet, if it's perforated, then it's already severe. I'm not going to do any quantification for that leaflet. If it's flail, flail means what? What do you mean for flail, Raj?
So, as in, sir, it won't be, so like flabby, I mean to say. So it won't be
when the two leaflets, they do not co-opt with each other.
Yes, sir.
When the one leaflet is prolapsing back, tip of the leaflet is prolapsing back into the LA. That is known as flail.
Yes, sir.
If somebody has got a flail leaflet, what will happen? It will be severe MR. So that's how we look at the severity of MR, by looking at the mitral valve leaflet morphology. If somebody has got a mitral valve regurgitation and patient has got a vegetation, what will happen? It has to be severe. So my quest first is always look at the morphology of the leaflet. If the morphology of leaflet is, and that will tell you whether this leaflet is mild, moderate, or severe itself, right? Let's stop this picture and see whether this leaflet is normal or abnormal. So I'm moving by frame by frame. So what is, Dr. Sadab, what is the morphology of this leaflet?
Yes, sir. One, sir. This leaflet, sir, is doming, sir. It's doming in the diastole, sir.
Where is doming? There's no doming, man, over here. Don't tell me doming is there. Where is doming, man?
Thickened, sir. Little thickened, this leaflet.
The leaflet is thickened. Anything else apart from thickening? There's a speck of calcification present over here. Look at the speck of calcification present over here.
Yes, sir. Yes.
And this leaflet, they are co-opting with each other, or they're not co-opting with each other?
Co-opting with each other, sir.
Correct. So their thickening is present. They have a little speck of calcification, and there is a co-optation which is present. And do you see any vegetation on these leaflets?
No vegetation.
Okay, you said no vegetations. Okay, I don't agree that there's no vegetations. I'll have to go back and show you the vegetations. What is this moving in and out?
Yes, sir. Yes, sir.
Vegetation present?
Yes, sir. Yes.
No, Siddharth.
No vegetation, sir. No,
so what is this then? These are freely mobile, a finger-like echo density, which is moving in and out. What is this?
Sir.
You are not reading, Siddharth. Dr. Pallavi. What is this, Pallavi?
Samples, so I don't know, sir.
These are codes.
What's your code?
Ruptured cordy.
No, ruptured cordy, only cords. Normal cords, which are seen like mobile echo density at the tip of the leaflets, the primary cords.
Okay, sir.
If there be a ruptured cordy, what will happen?
Leaflet will be
Because MR with
if the ruptured cordy is present, if it's a primary ruptured cordy, you will have a flail AML or flail PML, not AML, flail PML. Means the leaflet would be, tip of the leaflet would be back in LA. So morphology, it looks to be mildly thickened. There's a speck of calcium and they're co-opting with each other. So possibly they're the leaflet which are degenerative leaflets. There is no doming. So fair chances rheumatism is not there. Correct? Next point is severity of MR. So what Dr. Nanda told you, what is the most important reason? How do you look for severity of MR is? One single point, Dr. Bhimraya. Good morning, Dr. Bhimraya. Dr. Bhimraya has switched on his internet connection and has gone to sleep. Dr. Rahul Kumar?
Vena contractor.
Perfect, Rahul. Where do you measure vena contractor, Rahul?
Sir, at the tip, we switch on to 3D mode and then we have tip of the leaflet, sir.
At the
3D.
Yeah, at your level, we do not have a 3D. So at your level, what we have a color Doppler with 2D mode. So I'm going to stop this picture for you. Move frame by frame. So switch off colors now. So this is one leaflet, this is second leaflet, and the blood flowing between these two leaflets during systole is known as vena contracta. So in this is a point from where the blood is coming from between these two leaflets. I'm going to zoom up with you. Give me a second. So I'm going to measure. This is a point between these two leaflets from where the blood is coming back into the LA. 0.5 centimeters. Is that clear to everybody? Because this is the most important thing for any mitral regurgitation. You can hold me at this point. I can show you many times this point. The blood flowing back into the LA between these two leaflet tips. And if it is in color Doppler, color flow mapping, we measure the color flow mapping, how much this blood is flowing back in measurement of their distance between these two leaflets, and that we call as vena contracta. And this has a limit of 50 to 60. Because this is entirely dependent on this Nyquist limit.
So do you have any particular timing when we measure the vena contracta?
Correct. Very good question. You tell me at what time we should measure the vena contracta.
So the regurgitation occurs during systole.
Correct.
So
So look at this color Doppler over here. It's mid or late systole. Preferably at mid systole.
okay, sir. Thank you, sir.
So the most important point for any MR is calculation of vena contracta. That's one important point. Second is LV dilatation. As I showed you where to measure LV, we measure LV in diastole and systole just at the basal segments. If it's dilated, it's severe. If vena contracta is more than 0.7 centimeter or 7 centimeter is considered as severe. Then third point, what Dr. Nanda told you about all this is very famous previous point, like where we used to look at these kind of things. jet area versus LA area. And if a jet is eccentric like this, we add one more point. Correct? Fourth point, he says, when the jet regurgitates back into the LA, it will hit into the pulmonic veins. So what will happen? There will be systolic truncation of pulmonic venous flow. So we look at jet area, we look at LA area, and then the ratio of jet area versus LA area, and the systolic obliteration of pulmonic venous flow gives you a severity of mitral regurgitation. Now my question goes to Dr. Vivek Dwivedi. Vivek, are you there?
Yes, sir.
You have got multiple parameters, like you have got jet area, LA area, and then vena contracta. Which of these will say that severity of mitral regurgitation present? Which will take the best parameter?
Jet area, sir.
Jet area. Yes. So Vivek want to take jet area as a parameter for severity of mitral regurgitation. All right. So Vivek, Dr. Ashok. Ashok is there?
Yes, sir. Good morning.
Good morning, Ashok. So Dr. Ashok, Vivek says jet area he will take as a severity of mitral regurgitation. Would you like to take the same parameter? You want to take some other parameter?
ये भी तो डिस्चार्ज हो रहा है भाई, ये तो मैं क्या कर दिया?
अरे माइक को ऑफ कर दीजिए, डिस्चार्ज कर लीजिए, लेकिन माइक को ऑफ कर दीजिए. Ashok, which parameter you will take? Ashok is not also comfortable.
Yes.
कितने घंटे
jet and LA, sir.
Well, jet area, sir.
No jet area. Sanjeev, are you there?
Yes, sir, I'm here.
Sanjeev, my question is, we have one parameter of jet area, second parameter is LA area, third parameter is jet area versus LA area, fourth parameter is systolic obliteration of pulmonic venous flow, fifth parameter is vena contracta. Out of these 5 parameters, which one would you like to call a severity of mitral regurgitation?
So jet area versus LA area.
So vena contracta also, sir.
Who said vena contracta?
Sir, Amit Vikram, sir.
Amit Vikram said vena contracta. Now you have got a controversy. Amit, vena, why do you say vena contracta?
So both, sir. I think there are multiple, sir, parameters on which we can say there is the severity of mitral regurgitation, sir.
Okay. Now I'll have to explain why. Let me just show you how you do calculate jet area versus LA area. Just hold on for a second. I'll stop this clip for you. Go frame by frame. So I'll measure my jet area. How much is the jet area is? Comes out to be 8 centimeters square, right? And now I'll measure my LA area. This LA area is 27 centimeters square. So this is 8, this is 27. So what's the ratio? About 30%? So is that okay?
Yes, sir. Yes, sir.
Is
So
30%?
above 40 is severe.
30%.
More than 50 is severe, sir?
Anyway,
than 60 is
40,
severe.
50 is a severe. But do you think this is a non-severe aortic stenosis? Not severe. Please silence your mic, please.
It looks severe, sir.
It looks severe, but it's not severe by measurements. What's the problem?
So we have to take the linear blood flow as well.
Linear blood flow. This one. So linear blood flow, we have to take this linear blood flow also. You mean to say that? This area?
Yes, sir.
Is right to a large extent take this linear blood flow also into this area. She is very true. And that we calculate into mitral regurgitation. Is that okay? We have to look at a complete area of a regurgitant jet. Because the blood is swirling back into the LA and going back towards this. So we have to calculate this area also into the LA jet area. But what I wanted to tell you is, suppose I'm taking this jet area versus LA area, we do not put much emphasis on this as on today. Why we are not putting much emphasis? Suppose my blood pressure is high, I'm going to overestimate my jet areas. If my blood pressure is low, I'm going to underestimate my jet areas. If my LA pressure is elevated, I'm going to underestimate my jet areas. Because this jet area is dependent on the LV contraction. Is that okay? Is that clear? So we put more emphasis on vena contracta rather than on jet area. Dr. Subhash, your mic is making a lot of noises. First of all, you also make a lot of noises, and your mic is also making a lot of noises.
No, it isn't my mic.
Just mute it up. Mute it. So this jet area is dependent on definitely on driving force across LV and the receiving chamber. Receiving chamber is LA. If my LA pressures are elevated, obviously I'll have underestimation of my jet area. So the take-home message for mitral regurgitation is always spend time on vena contracta. Clear? And we have to measure vena contracta in always flat view, not in 4-chamber view. If you have a dilated LV, vena contracta more than 0.7 centimeter square, 0.7 centimeter, then possibility of severe mitral regurgitation is very true. Any questions before we move on to aortic regurgitations?
Good morning, sir.
Good morning.
Sir, can you please explain the measurement of vena contracta once again, sir?
Okay, I'll do that again. So this is a picture which has got a mitral regurgitation, right? So I'll first switch over my colors and then stop my frames. So this is one leaflet, this is another leaflet. This is AML, this is PML. During systole, the blood will regurgitate back from between these two leaflets. Is that okay? Then I switch on my colors. I'm going to get, after switching my colors, from where my regurgitant jet is happening. So I'm going to go to that frame from where my regurgitant jet is happening. So this is a place from where the regurgitant jet is happening. So I'm going to measure this. This is a point from one point to another point. My regurgitant jet is happening. It's almost 0.5 centimeters square, 0.6 centimeters square. The distance between the 2 points from where we can see a color jet with the Nyquist limit between 50 to 60. Because if you increase the Nyquist limit, this will become smaller. If you reduce the Nyquist limit, it will become bigger. So go back to your office tomorrow and do this in any patient whom will get a mitral regurgitation.
Excuse me, sir, I have a question.
Go ahead.
Thank you, sir.
How would you define the severity of the vena contracta?
If the vena contracta is more than 0.7 centimeter, it's severe.
Thank you, sir.
Severity of MR is when you have got a vena contracta more than 0.7, jet area versus LA area, and then mitral flow velocity more than 1.7 centimeters square, so more than 1.7, and then dilated LV.
Excuse me, sir.
Go ahead.
Sir, but this we have to like calculate this size of vena contracta within the regurgitant orifice. So
always
I'm
in
not
the
clear about that. Okay.
Vena contracta would be in regurgitant regions only.
Okay.
Another question, sir.
Yeah.
So would the blood pressure change the size of vena contracta?
Will not. Blood pressure will change the size of jet area, not the vena contracta. I don't say it's 100% independent, but it's load independent. That's what I was trying to explain to you. Why don't I spend time more on a jet area versus LA area? I'll spend more time on vena contracta. As I said, mitral stenosis, planimetry. Aortic stenosis, LVOT diameter. MR, vena contracta. AR, vena contracta. I'll forget everything in the word. If I'm looking at AR, always vena contracta and holodiastolic reversal of flow in descending aorta. I'll be coming to that in a couple of minutes.
Sir, can you zoom this picture? More, sir.
I'll try.
Why not vena contracta is this narrowest point?
Here?
Below the level where you have measured, below this horizontal narrowest point of this jet.
Here?
Yes.
I switch off a color and then you see where I'm measuring the vena contracta. It should be between these two leaflets, not over here. My leaflets are over here.
Okay, sir.
So even this I'm overestimating. Ideally, I should be measuring again. Let me go back to measure again. Then I'll measure. It will be still less. I'm sorry. The colors have gone again. So if I have to measure, I'll measure still little less over here. Now I'll just save and then go to control, switch on my colors. So I'm measuring between these two leaflet tips.
Okay, sir. So we have to compare the 2D and color side by side.
At your level, you can compare that because these are two leaflet tips with which from where the blood will start originating at the between the two leaflets.
Okay, sir. Vena contracta is always at tip level.
Obviously. Perfect. Now you got the exact answers. Okay. Like stenotic will happen. I said stenosis will happen between the tip of the leaflets. So regurgitant will also happen with the tip of the leaflets.
Okay, sir. Thank you.
Sir, is it more the number in the vena contracta that is less severe, sir? Or is it the other way?
More the number, more severity. If it's 0.7, it's severe. is less than 0.7 is not severe.
Understood, sir. Yes.
So if it is less than 7, sir, then how do we confirm it if it is not severe mitral regurgitation?
If less than 0.7 is, you go back and look at your LV diameters.
Okay.
If your less than 7 centimeter is there, your LV has to be normal.
Okay, sir.
All right. Let's go to. Yeah, go ahead. Go ahead.
Sample volume pulse wave on mitral valve can also helpful to assess the MS.
Sample volume at the mitral valve will do what?
By measuring the velocities.
Velocity is suppose 2 meters per second. Velocity is 2.5 meters per second. What's going to make a difference? Velocity will increase if you have a severe mitral, but that's not going to tell you that's severe or non-severe.
Okay, sir. Okay, sir.
Okay, let's go to the last one, aortic regurgitation. So I'm going to show you the aortic regurgitation. Dr. Nanda was the first person who did all this work. Like the credit goes to Dr. Nanda. Everything in aortic stenosis has been shown by Dr. Nanda itself. Like he was pioneer when he devised aortic regurgitation. Severity of aortic regurgitation. All right. So first moving clips. No. Now look at this aortic regurgitation. Now we are not looking at the flow. We are looking at, let's switch off our colors first. Now look at this valve. This valve is thickened. It's opening reasonably well. If I switch on the colors, what does we see? We see aortic regurgitation flow. Now, how do you say the aortic regurgitation flow is severe or non-severe? Correct? So I'm going to freeze this film for you and move frame by frame. So when does the aortic regurgitation start? Systole or diastole?
Diastole, sir.
Diastole. And mitral regurgitation?
Systole, sir.
Systole. So I'm going to go to my frame to end systole. So I'm gone to end systole. Now I'll go to diastole. Now look at this cursor over here. Where it is, in diastole or systole?
Systole.
It's diastole, man. End of a T wave is diastole. Don't tell me systole. Correct? So in diastole, between the two leaflets, what you see is vena contracta. Now I'm switching over off colors. So here the two leaflets are. Switch on colors. So this is a vena contracta for aortic regurgitation. Right. Let's measure this vena contracta. How much it is? Almost 1 centimeter. You can do it as many times as possible. Is that clear? I'm switching off colors again. Tip of the two leaflets from which vena contracta is originating. And this is known as AR vena contracta. And this is the most important thing in aortic regurgitation. To look at vena contracta. Then comes next important thing is jet with height oblique LVOT height. So this is vena contracta. We come towards LVOT. We measure the jet with height oblique LVOT height. Now, when the blood flow will regurgitate back into LV, it will broadens up. It becomes larger in size. Vena contracta is over here. The jet is over here in LVOT. So we measure jet with height oblique LVOT height. So we have measured this jet width height is over here and LVOT height is over here. Jet width height is 1.58. LVOT height is 2.4, is more than 60% of the area. Vena contractor, there's a confusion over here because many people will take this as a vena contractor. No, vena contractor will originate at the between the tip of the leaflet. When the jet goes back into the LVOT, it broadens up or widens up. So we measure at the LVOT level the height of the jet, regurgitant jet versus height of the LVOT. And
Sir,
the
can you
ratio
not
of
get them all in one frame, sir?
this will happen only in one frame only.
Sir, including the vena contracta
No,
and
not vena contracta. Vena contracta is way away. Vena contracta was over here. This is at LVOT level. Let me just.
Yes, sir. All three not possible in one frame, sir.
No, all three are not possible. Look, vena contracta would be here. As it come back, it will widens up. So this is LVOT diameter. And then the jet height would be over here. So I'm switching over my CFM again. Look, vena contracta is somewhere over here. So I can only focus on a vena contracta or I can focus on jet width height. Correct? So let's look at a running frame now. Then you will realize. Now you can see how much the regurgitant width is, jet width is. Is almost this much is the jet width. This patient is posted for surgery in a couple of months. Let me stop it for you. Move frame by frame. Not happy. At least I'm not happy. Now I'm happy, little happy. So this is LVOT diameter. I'll measure the LVOT diameter from this point to this point and the jet width height at this point to this point. So almost more than 50%. Clear? These are the two important things, jet width height oblique LVOT height with vena contracta, and third is LV diameter. Next most important point in aortic regurgitation is we go to descending aorta. What do we see in descending aorta?
Flow reversal. Diastolic flow.
Holodiastolic reversal of flow in descending aorta. We go to suprasternal window. No, it's not shown in this picture, but let me just show you one more thing before I move to, which is known as pressure half time of AR jet. So this is a pressure half time of AR jet. I think that'll be better if I show to something else. Just give me a second. Can you see the slide now? Is that comfortable? You can see the slides, Ravi?
Yes. Yes.
Okay. So we measure from a top. I can go and measure it for you again. The pressure half time. AR pressure half time from this peak to this bottom. From this peak to this bottom. So pressure half time is 399, 342. So this is somewhere in between moderate. But the most important part for any aortic regurgitation would be to go for a holodiastolic reversal in descending aorta. So let me just go to the holodiastolic reversal of flow in descending aorta. Yeah. So this is aorta in this pulmonic artery in the centers and descending aorta flow. And when I put my continuous wave Doppler across this descending aorta, what should we see? I could only see a blue flow away from a descending aorta. I do not see any red color into the descending aorta. So red color would be during systole or diastole, Ravi? Dr. Ravi Kumar Singh. Dr. Ravi Kumar Singh is not there.
Hello, sir. Good morning.
Are you there, Ravi?
Yes, sir.
So the regurgitant jet would be seen in diastole or systole?
Sir, you can see jets in diastole, sir.
Okay. So we do not see any jet of regurgitation flow in this particular frame. So only systolic flow which you are seeing over here. If you happen to see a diastolic flow, holodiastolic means in all through diastole, that is holodiastolic reversal of flow. And if you put a continuous wave Doppler over here, as we did it, we could see some amount of flow, but it's not a significant regurgitant flow. We'll see a Doppler flow reversal over here, seen over here. And that, if you parameterize it, it will give you a velocity of VTI of more than 22 and end diastolic velocity of 22. So let me just look at this particular phenomena. Let me measure it. This is possibly some amount of regurgitation which is present. So I'm going to RVOT trace. I'll pick up anything. I'll pick up caliper. So I'm going to measure this as VTI. No, it's not picking up. Sometimes these artificial intelligence, they really make a lot of problems. So this artificial intelligence is telling it, this machine, look, this is not RVOT mean. So RVOT, VTI, let's try if it's agreed with RVOT. No, it's not talking about all this thing. So what do we do exactly is we trace this Doppler envelope from here till this point. If this VTI is more than 22 and end diastolic velocity is more than 22, we consider them as severe aortic regurgitation. Correct. So let's comprise what are the points for a severe AR. First and foremost point of severe AR is vena contracta more than 0.7. Then second is jet width height oblique LVOT height in same plaques window more than 50%. LV has to be dilated. Pressure half time between less than 250. And last is holodiastolic reversal of flow in descending aorta to talk about severe aortic regurgitation. So my last question to Dr. Ishwar. Dr. Ishwar, are you there?
Yes, sir.
What is the most important clinical sign for aortic regurgitation?
It's a clinical sign. Echo.
Right. Echo, I told you. What is the most important clinical sign for aortic regurgitation?
So the difference between the systolic and diastolic blood pressure.
Correct.
Is a huge.
Suppose my blood pressure is 120 by 80. Do you call them as severe aortic regurgitation?
No, sir, it should be like 120 and 40.
Correct. So if you happen to see a patient whose blood pressure is 120 by 80 and by clinical diagnosis is not a severe aortic regurgitation, and you see aortic parameter as severe aortic regurgitation, which one you will take? You will take aortic parameter, BP parameter as true or echo parameters as true?
Echo is visual. I think echo.
No.
If patient has hypothyroidism, then hypo in hypothyroidism.
No, not at all. Whatever we see in echo is indirect hemodynamic parameter of clinical conditions. So if you happen to see a blood pressure of 120 by 40 and your echo 120 by 80 and your echo parameter says severe aortic regurgitation, you have to go back and look at your echo parameters.
Okay, sir.
So that's what take-home message is. So if I have to comprise everything in MR and AR is, the most important parameter for MR AR is, without which I'll not be able to say severe aortic regurgitation, severe MR. What is the most important?
Vena contracta.
Most important parameter is LV dilatation.
Okay.
The second important parameter is vena contracta. So we have to rely more on a vena contracta rather than anything else. Then MR, you can use other parameters like jet area versus LA area. Then systolic truncation in MR. And then next is like flow velocity across mitral valve, which is increased. In AR, we have to rely on jet width area oblique LVOT area, LVOT diameter, jet width height oblique LVOT height, and then holodiastolic reversal of flow in descending aorta and pressure half time. And that's how we look at these valvular regions as far as mitral and aortics are concerned. Is that comfortable?
Yes, sir.
Shall I stop it over here? Any questions from anybody?
Sir, you have
Dr. Prasanjit, here you have explained well, but I am still not comfortable with that AS, sir. I don't know. I'll have to read, I think.
AS, what is the problem with AS, Dr. Prasanjit?
When I see the AS, I don't know what to do, how to measure the severity and everything. I'll go and play with the echo machine. Then maybe next time I'll.
The best part of a AS is look at the LVOT diameter, look at LVOT VTI, look at an aortic valve Doppler spectrum pattern, calculate continuity equation, get a peak velocity across aortic valve and a mean gradient across aortic valve. You can still ask any questions whenever you feel like. Just put on a WhatsApp. Dr. Saurabh, any questions?
Sir, while measuring the vena contracta for MR, so plaques is better or fourth chamber?
Plaques, always plaques.
Okay.
Sir.
Venkatesh, go ahead.
Sir, to know the severity of MR or AR, we should how to tell the severity by seeing the jet and the diameters.
Seeing the severity by?
Severity by jet and the diameters. Like to metal, mild, moderate, and severe. The
Well,
jet is
what
to
exactly majority people do just go to 4-chamber view, see how much the jet is, whether it's taking to 1/3 of LA, 2/3 of LA, or 3/3 of LA. So many people they do this with mild, moderate, severe. If my point is, if vena contracta is less than 7, I'll say progressive MR. If vena contracta is more than 0.7, I say severe MR.
Okay, sir. Okay, sir. Thanks.
Dr. Rashri Karat.
Sir, can you show me one of the example for the pulmonary vein Doppler in presence of severe MR? Is it available?
You want to see like how does it happens, right?
Patterns, yes, sir. Patterns. Yes, sir.
Just again, give me a second.
Yes, sir.
Sir, in just a second, give me a second. All of you can see my slides?
Yes, sir.
Yes, sir.
Okay. Now look at my slides. This is systole. This is mitral regurgitation. And my sample volume is in the pulmonic vein right now. Can you see my sample volume in pulmonic vein? This is 4-chamber view, this is LA, and this is pulmonic vein. My sample volume is right in the pulmonic vein itself. So when the jet is regurgitating back, normally S wave would be taller than D wave. Here the S is very small, truncated, and D wave is large. This is here ECG gating. You can appreciate this now?
Yes, sir.
So very small S wave, very large D wave. So what is exactly happening with systolic regurgitation? This S wave has become small. At this time, not significant flow is coming from pulmonic vein to LA. So it's truncating that pulmonic flow during systole. That is known as systolic truncation.
Okay, sir. Thank you.
Right.
Sir, in AR diastolic reversal flow, can you explain once again?
AR diastolic reversal flow. Okay.
Just in echo, how do we see the Doppler pattern? That is what I want to.
I'm going to show you that. Just give me a second because.
Okay, thank you, sir.
$78. All right. Can you see this slide now?
Yes, sir.
It'll take for a second. Just give you because computer is not able to adjust so many demands in one go. So yeah. So this is a reversal of flow in descending aorta. This you can see red in color. This is systolic forward flow, and this is all holodiastolic reversal of flow in descending aorta. Can you see this holodiastolic descending aorta?
Yes, sir.
We have traced this Doppler flow pattern, reversal flow. Look at the velocity. VTI is more than 22, 33.6, and diastolic velocity is almost more than 20 or 30. You draw a line from here to straight line over here. It is more than 20 centimeters. That's how it looks at severe aortic regurgitations.
Okay, sir. Thank you.
All right. Anybody else?
Yes, sir. Hello. Myself, Anuj Kumar, sir.
Go ahead, Anuj.
So, in case of severe AR, sometimes it obstructs the opening of the mitral valve, so that it looks like the patient is having mitral stenosis as well.
Okay.
So, how to confirm that the mitral stenosis is functional or there is any real defect in the mitral valve as well?
Take a mitral area by pressure of time. Or you can do a planimetry mitral area.
Sir, planimetry measures the maximum opening of the mitral valve.
Right.
So when the regurgitant jet is obstructing the opening of the mitral valve, does it affect the overall MBA by planimetry?
It will not affect, but if it will not affect in planimetry, it only says that you will see a fluttering of AML, but is reduces the opening of the mitral valve, but it will not affect planimetry. It will not affect jet gradients. It will not affect Doppler spectrum pattern. Unless until is a true mitral stenosis. It'll just give you a fluttering because the jet is hitting back on AML.
Because sir, I saw one patient in my OPD, sir. The opening of the mitral valve was very small. It looks like that the patient is having very severe MS. But actually, it was not MS. It was due to the severe AR that is not allowing the mitral valve to open. So I had a confusion that in penimetry also the MVA will come small because we measure MVA in penimetry at the tip of the mitral valve, but the AR is not allowing the MVA to mitral valve to open completely.
Okay. Then the next answer for that is it's not allowing completely. Such a severe AR is present. It's not allowing mitral valve to open completely. Then look at the mitral valve thickening. Look at the other parameters.
Thickness was normal, sir. Mitral valve was normal.
That's what I'm saying. If the mitral valve is opening, mitral valve is normal and is not AR is not actually opening it up, is not going to make much difference. If you will take a pressure gradient across that mitral valve also, the mean gradient will not be very high. Peak could be high, but not the mean gradients. Right?
Okay, sir. Thank you, sir.
Hello.
Oja,
hello, sir.
Yeah, Dr. Oja,
Yes, sir.
go ahead.
Yes, sir. Sir, in the mitral stenosis, the Wilkinson scoring is still valid?
Yes, it is valid.
Okay, sir.
But we add 4 more parameters from our center. Wilkinson's is thickening, subvalvular calcification, then mobility, and
Caudal involvement.
Caudal involvements. Then we add LA appendage thrombus, LA thrombus, MR jet, and commissural thickenings.
Commissural thickening. Okay.
So we add 4 more parameters from JROP to call them as the severity for intervention.
Okay.
Suppose LA thrombus is present, LA appendage thrombus is present, MR is severe or commissural calcification. These people are not valid for balloon valvotomy.
And pulmonary artery pressure, sir?
Not significant.
Okay, sir. See. Thank you, sir.
Dr. Venkatesh, anything you have to ask?
No, sir.
All of you are tired?
Yes, sir.
Dr. Saurabh says, yes, sir, tired.
Tired and hungry.
But sir, morning session was good than the evening, sir. It's refreshing, sir.
Refreshing, good.
The last question, sir.
Go ahead.
Sir, in pressure of time, sir, if a slope is more deeper, then that will be considered as severe AR, and if it is slope is not deeper, then it will be considered as moderate.
You could take that parameter.
Okay.
Dr. Deepak, go
One
ahead.
question.
Yeah.
Sir, in case of AR, can we measure jet width in 5-chamber view with color?
No, certainly not.
No.
No.
Okay.
For calculation of severity, we cannot. Otherwise, many people, they look at a jet width in 5-chamber, 3-chamber, say that is severe. This is not true. This is not correct. All right, no more questions.
Sir, books, we are not got yet books, study material.
Rajesh, I'll just note down because we sent a book almost 1 month back. So what I'm doing is I'm sending them again who has not received them. Fortunately, unfortunately, what we did, we sent by a reliable courier, which is next door to our place of work. Rajesh, which is your courier company nearby to you?
Here, sir, we have DTDC.
Okay.
I will check it, sir, and I will message you.
Put on a WhatsApp. Anybody who has not received the book, send me along with the courier company. I'll send another book by courier company.
Okay. Thank you.
Whatever the courier company will say, I'll send it to that courier company. Because it's very difficult. Like we are trying to trace them up, and those say they have got the book. Somebody says they have been delivered. But next time I'm not going to do that. I'm looking at your courier company, and I'll send it through that courier company only.
Yes. Thank you.
All right. Shall we stop it over here? I'll quickly take the attendance. If it's possible, I'm sure like many of you are present. So, Dr. Nitin, are you there?
Yes, sir. I'm here.
Dr. Pratibha Dhingra?
Yes, sir. I'm there.
Dr. Veerwar Jha?
Yes, sir. Present.
Ankit Seni? Panipat. Shashank Susi?
Sir, present. Sir, present. Ankit Seni present, sir.
Okay, Ankit. Dr. Shashank Tuse? Nasik. Dr. Shashank Sunil Tuse? Dr. Shivaji Vitoba Mali?
Yes, sir. Present, sir.
Dr.
Present.
Yeah, I got it. Harshvardhan Kuri? Dr. Harshvardhan Kuri? Dr. Pallavi Horo? She was present. Dr. Anchal Dikshit? Dr. Anchal Dikshit, Lucknow. Dr. Saurabh Gupta?
Yes, sir. Present.
Dr. Arnab Kumar Mandal, Madinapur. Dr. Avinash Solanke?
Yes, sir.
Dr. Sangeeta Chaudhary, present. Dr. Ashok Yadav, present. I saw you already, Sangeeta. Dr. Virata Devarama? Dr. Venkatesh B.S. Gode?
Present. Present.
Piyush Pandey, Gondia. Pankaj Kumar Mishra, Bhubaneswar. Kiran Vasarao Birari, Nasik. Kiran, are you there? Dr. Rota Singh Kalsi?
Present, sir.
Present, okay. Dr. Sandeep Kumar, Delhi.
Present, sir. Present, sir.
Dr. Prakhar Gupta, Firozabad.
Sir, Sandeep present.
Sandeep, I marked you already.
Okay, sir. Thank you.
Dr. Prakhar.
Sir, present.
Dr. Chitranjan Thatai. Katak. Dr. Sarada Prasanna Sahu. Dr. Subhash Chandra, present from Agra. Dr. Sofirul Islam. Dr. Pranjal Prakash Jagtap, Nasik. Dr. Deepak Suman. Present, Deepak. Dr. Rupali, present.
Yes, sir. Present.
Dr. Ashna Kishore Sinalkar.
Present, sir.
Dr. Madhurima Datta, Silchar. Dr. Mahesh Padsalke, Navi Mumbai.
Yes, sir. Present, sir.
Dr. Bhagat Vibhusha Vishwanath.
Present. Present, sir.
Dr. Dheeraj Kumar Singh, Delhi. Dr. Sanjeev Mathur from Jaipur, present. Dr. Niranjan Agarwal, Bhilai.
Present, sir.
Dr. Bhimaraya, Bangalore. Dr. Rajesh Gudade, present. Dr. Rahul Kumar, Delhi.
Present, sir.
Rahul, you did not ask me anything, man.
Sir, I asked you that reversal of diastolic flow.
Okay, okay. Thank you. Dr. Karthikeyan. Dr. Ravikant Gupta.
Yes, sir.
Ravi, are you sleeping or you just woke up?
Awake already. Attending home.
You just woke up, right?
No, sir.
Okay. Dr. Subhash Chandra from Mohali.
Yes, sir. Present, sir.
Subhash, your other counterpart was very active today.
Yeah, I know, sir.
Dr. Khushpreet Singh, Chandigarh. Dr. Umesh Kumar Ojha was present. Dr.
Yes,
Amit
sir.
Vikram, Munger.
Yes, sir. Yes, sir.
Okay. Dr. Rashri Karat was present. Dr. Rajendra.
Present, sir.
Yeah, I know. Rashri, I know about it. Dr. Rajendra Borkar.
Yes, sir.
Yes, sir. Raj Borkar.
Raj Borkar. Swapnil Datta was present.
Sir, present, sir.
Yeah, I know. Parveen Kumar, Danapur, Patna. Parveen, are you there? Dr. Prashant Pandey from Varanasi.
Present, sir.
Dr. Ravi Kumar Singh, Bihar.
Yes, sir.
Dr. Ankit Agarwal, Bareilly. Ankit, are you there? Dr. Ravi Neelkant Patil. Dr. Sanika Sachan Kadam was present.
Present.
Yeah, I know, Sanika. Anuj Kumar Devgar.
Yes, sir. Present, sir.
Dr. Deepak Kumar Ghaziabad.
Yes, sir.
Deepak Ghaziabad.
Yes, sir. Yes.
Niharika Chirola. Dr. Niharika.
Sir, my name is not coming.
Your name will come, man. Hold on for some time, man. Dr. Vivek Kumar Dwivedi, Loni.
Yes, sir. Present, sir.
Dr. Narendra Sharma, present. Dr. Devendra Pratap Yadav, Varanasi. Dr. Iqbal Mahmood, Dhaka, Bangladesh. Iqbal, are you there? Mohammad Sedeb Raja was present. Dr. Anuj Jain Khargaon. Anuj Jain Khargaon. Aarti Jadhav, Mumbai. Aarti,
Yes,
are you
sir.
there?
Present. Present,
Okay,
sir.
Aarti. Dr.
Yeah.
Santosh Kumar Bardwan. Dr. Sunita Kaul, Delhi. Sunita, are you there? Dr. Paresh Alwani, Nasik. Dr. Pasanjit Panda was present. Dr. Sheetal Bodke, Nasik.
Yes, sir. Present.
Dr. Raghavendra. Dr. Prakash Raichur, Karnataka. Dr. Niharika Terhan.
Sir.
Niharika, are you there?
The Nikita. Present, sir.
Sorry, Nikita Terhan. I'm so sorry about it. I'm so sorry about your name. Nikita, you did not ask me anything, like I'm not really happy with you. I don't know whether you're reading or not. You just got into this program because of one of my friends, and I don't listen any questions from you, Nikita.
I've been reading, but yes, it is a steeper learning curve for me because I have less access to ECOs as compared to others.
Okay.
And less in-person guidance also. But yes, I'm learning. I was 0. I think I'm at least 2. And it's a steeper learning curve. But yes, I'm reading.
Okay, all right. Great. Dr. Amit Kumar Singh. Anybody else left?
Hello,
Swami
sir.
Ishwar.
Dr. Ravi Kumar Singh, sir.
Ravi, you just joined, man.
Sir, my internet connection was cut off, sir, at that time, sir.
Okay, I'll mark you Ravi Kant Singh. Ravi Kant Gupta, right?
No, Ravi Kumar Singh, sir. Ravi Kumar Singh.
Ravi Kumar Singh. I'll just mark you present, Ravi.
Okay, thank you, sir.
Swami Ishwar.
Doctor?
Ishwar.
Sir, there is one request from my side. I'm Dr. Subhash. At the moment, I'm in Chester, UK. And I got up at 1:30 in the morning, and it is 4 o'clock now. So next Sunday, please don't make it in the morning.
Okay.
There's 5.5 hours difference.
Okay,
So,
Dr. Subhash, I'll take care of your age. Don't worry about it.
At 7 o'clock, I had to get up at 1.
I'll take care of it.
Okay, thank you. Thank you.
Are you coming back, Dr. Subhash?
I will come back on 9th of December. Then there will be problem.
After that, I can take it in the morning, right?
Yes, yes. Next week it will be problem.
Okay, all right. I'll take care of everybody, man. And I have to take care of you more than anybody else.
Yeah. Thank you,
All right,
sir.
guys. Yeah. All okay, okay, guys, we'll stop it over here. And now you can enjoy your evening with the family and everybody, and send me on your WhatsApp how was the day today and did we do good or bad, and how was your family reaction. Okay. Ashok present. I marked you present, Ashok.
I'm Ishwar, marking present, sir.
I marked you present, Ishwar also.
Thank you, sir. Good day, sir.
Okay,
Sir,
take
the
care,
book
doctor.
doesn't contain the normal pressures that you just explained in one page or one go, sir.
I'll send you those. I'll send
Sir,
you.
full, sir. LVIDD, LVIDS, including the
I'll send you all those
pulmonary
clips.
veins,
Yeah.
mean gradients, everything, sir. Everything that you
I'll
should,
what I'll
including
do.
VTI.
I'll do what I'm going to do is I'll send you one page of every lesion.
Yes, sir. Yes, sir.
In one page, you will see all the parameters.
Yes, sir. Yes, that would be fantastic, sir. If you can if you can attach this to the book that you have sent and bind it like, spirally, that would really last long with us, sir. Because the other thing is it is coming off, sir, the pages, what I feel. That you please look at it, sir.
The book has become of age of Dr. Subhash Chandra,
Yes, sir. Okay, sir. Okay, sir.
And Nitin, I happened to meet your father in Hyderabad.
Yes, sir. He showed me the picture, sir.
Yes.
He was very happy. Yes, sir.
At one time, your father was a student, and now you are a student.
Yes, thank you, sir. I'm actually happy being your student, sir.
Generations are
Yes, sir.
getting learned
True, sir.
over a period of time.
True, sir.
It's
Thank you,
great
sir.
and-
Thank you for
and-
being my teacher, accepting me as a student. I'll be with you, sir. I will be with you for a very long time.
Sure, definitely. And your father was very happy. He said, like, my son is at number 1. He's in your class. I said, I remember very well.
Yes, sir. Thank you so much, sir.
All right. God
Good day
bless
to
you.
you, sir.
Take care. Stay safe and see you next week. Bye-bye.
And sir, these things are values, please, sir. Don't forget.
Sure, I'm not going to forget.
Yes,
Definitely.
thank you, sir.
Bye-bye.
Thank you. Good.